Tinnitus, the persistent perception of ringing, buzzing, or hissing in the absence of external sound, affects millions worldwide and is often dismissed as an enigmatic and untreatable auditory disturbance. While commonly linked to hearing loss, noise exposure, or vascular issues, a growing body of research is beginning to explore a more nuanced and underappreciated contributor: vitamin B12 deficiency. This connection, though rarely discussed in mainstream clinical settings, offers a compelling biological explanation rooted in the integrity of nerve conduction and myelin health, factors central to auditory perception and neural signaling. Vitamin B12 plays a pivotal role in maintaining the myelin sheath that insulates and protects nerves, including the delicate auditory nerve pathways that carry sound signals from the cochlea to the brain. When B12 levels drop, the demyelination process may begin silently, progressively impairing the transmission of electrical impulses. In the auditory system, even subtle disruptions in signal fidelity can result in abnormal sensory input being interpreted by the brain as phantom sounds, tinnitus. This concept of neural noise generated by faulty or hyperexcitable nerve fibers aligns closely with the experiences of tinnitus sufferers and suggests that in at least some cases, the symptom may be neurologically rooted in a reversible deficiency. What makes this link particularly fascinating is that many people with tinnitus report no measurable hearing loss on standard audiograms. This has long puzzled clinicians, but it fits the profile of subclinical B12 deficiency, where nerve damage can begin long before traditional blood tests or imaging studies reveal any abnormality. The auditory nerve is highly metabolically active and requires continuous support from nutrients involved in methylation and mitochondrial function, both of which depend on adequate B12. When this support falters, the nerve may begin to misfire or transmit distorted signals, contributing to the perception of internal noise. Emerging clinical studies support this hypothesis. Several small trials have reported that individuals with tinnitus are significantly more likely to have low serum B12 levels compared to matched controls, even when those levels fall within the conventionally accepted normal range. In some of these studies, B12 supplementation, particularly in high-dose methylcobalamin form, led to reductions in tinnitus severity, especially among patients with documented deficiency. Although not a universal solution, these findings suggest that for a subset of tinnitus sufferers, the condition may be at least partially reversible through nutritional repletion. Another layer of intrigue lies in the role of B12 in regulating vascular tone and reducing homocysteine, an amino acid that, when elevated, is associated with endothelial dysfunction. The microvasculature that supplies the cochlea and auditory nerve is extremely delicate, and even minor circulatory compromise can impair oxygen delivery and increase oxidative stress in auditory tissues. B12, by facilitating homocysteine clearance and supporting nitric oxide production, may help preserve vascular health in these sensitive regions. This suggests that B12 could benefit tinnitus sufferers not only through neural repair, but also by improving cochlear blood flow, an often overlooked factor in auditory pathologies. Additionally, B12 is indirectly tied to neurotransmitter balance, particularly dopamine and serotonin, which influence auditory perception and emotional processing of sound. Many tinnitus sufferers report heightened anxiety or depression, which can intensify their awareness of the condition. Since B12 supports the synthesis of mood-related neurotransmitters, correcting a deficiency may help mitigate the psychological amplification of tinnitus, reducing both the volume and emotional burden of the phantom sound. Despite these promising avenues, awareness remains low. Tinnitus patients are rarely screened for nutritional deficiencies unless anemia or other overt signs are present. This leaves a significant diagnostic gap, particularly for individuals with unexplained, idiopathic tinnitus who may have never considered their diet or absorption capacity as potential culprits. Older adults, people with gastrointestinal disorders, vegetarians, and long-term users of acid-reducing medications are all at higher risk for B12 depletion, yet tinnitus is seldom recognized as a potential warning sign. From a therapeutic standpoint, B12 is safe, accessible, and inexpensive, making it a low-risk intervention for tinnitus, especially when deficiency is suspected. Methylcobalamin, in particular, may be more effective for neural repair due to its bioavailability and direct action on nerve tissue. While B12 is unlikely to be a cure-all, tinnitus is a multifactorial condition. It could serve as a powerful adjunct therapy or even a root cause remedy for a portion of patients. Importantly, It represents a shift away from the resigned view of tinnitus as something to be merely managed toward a more proactive and potentially restorative approach. Ultimately, the overlooked connection between B12 and tinnitus invites a broader rethinking of how we approach seemingly untreatable sensory symptoms. Instead of viewing tinnitus purely through the lens of audiology, we might consider it a signal of underlying metabolic imbalance or neural distress, an early whisper of a system in need of nutritional repair. As our understanding deepens, B12 may emerge not only as a critical factor in preventing irreversible nerve damage, but as a hopeful bridge between nutritional science and the quiet suffering of those who hear what isn't there.